Good afternoon. My name is Susan Howlett, and I'm a professor of pharmacology and geriatric medicine at Dalhousie University in Halifax, Nova Scotia in Canada. And it was my pleasure today to moderate a session on sex differences in cardiovascular disease, a really important topic. And it's my pleasure to introduce Dr. Jaffe, who is one of the speakers at the session.
Thank you. Hi, I'm Iris Jaffe, and I am a professor of medicine at Tufts Medical Center and Tufts University School of Medicine. And I spoke today in this session on the topic of sex differences in the mechanisms of heart attack and stroke.
And I guess I'd like to ask you a couple of questions. Maybe first off, you could just summarize for us some of the highlights of the work you presented today.
Yes, so we all know that there are impressive epidemiologic differences in the incidence of heart attack comparing males and females. So young women are generally protected from heart disease. They lose that protection within about a decade or two of menopause and catch up to men in their 70s. And by the time they're in the 80s, actually women have more heart attacks than men. But the mechanism is still not totally clear. And so we've been studying the role of the mineralocorticoid receptor in this process. So the mineralocorticoid receptor, many people know as the receptor for aldosterone, which regulates blood pressure in the kidney. But it turns out it's also expressed in endothelial cells, where we showed it contributes to vascular inflammation in atherosclerosis, but it does so in a sex-specific way.
Well, that's really exciting finding, and it has huge implications for cardiovascular disease. So quite often women have protective effects early that may be mediated by estrogen, but then as menopause comes on, some of these are lost. Have you any evidence for that type of phenomenon?
Our research is very basic, so it was mostly performed either in cultured human vascular cells or in mouse models. So we haven't really looked specifically at menopause, but what we discovered is that in vascular endothelial cells and in white blood cells, the mineralocorticoid receptor regulates adhesion molecules that can recruit white blood cells to the blood vessel and leads to increased vascular inflammation. But we went on to show that the estrogen receptor, which is also a steroid hormone receptor, in females can interact with the mineralocorticoid receptor in the nucleus and inhibit the mineralocorticoid receptor for driving these inflammatory genes. And as such, female mice, for example, have less inflamed atherosclerotic plaques when compared directly to males. And in males, if we delete the mineralocorticoid receptor, their plaque inflammation is decreased. And in females, there's no difference. And I think that's because the estrogen receptor is already inhibiting inflammation in the females.
That's really interesting. And do you have any information about whether testosterone receptors change in later life?
Yeah, so we haven't specifically looked at that, but that's a great question, right?
Mm-hmm.
So there's lots of potential reasons for the sex differences.
Yep.
We've focused on the estrogen receptor and its interaction with the mineralocorticoid receptor, but whether androgens are also contributing, either in males or females, remains to be studied.
So continuing on, I'd really like to know something about whether you think mineralocorticoid receptor antagonists might have any sort of a role in this pathophysiology.
Yeah, that's a great question. So mineralocorticoid receptor antagonists, are approved to treat both high blood pressure and heart failure. But if you look often in the clinical trials from heart failure, you'll see that there's a decreased incidence of heart attack in those that are randomized to a mineralocorticoid receptor antagonist, even though those are typically secondary endpoints for which maybe the study wasn't powered. Mm-hmm. So some of the results that we've shown might suggest that mineralocorticoid receptor antagonists could be beneficial in males of any age and potentially in postmenopausal females to prevent heart attack and stroke.
So you've seen some real evidence for sex-specific effects that may implicate not just disease progression, but also disease treatment in a personalized way, for example. So your research is really showing how important it is to look at both males and females. I wonder if you could comment on that.
Yes, so we recently reviewed the literature, and there's over 10,000 studies using mouse models of atherosclerosis in the literature, and it turns out that less than a quarter of them use both sexes in the study. Typically, most use just males, and I will say that when we started, we used just males, and only in the last 5 or 10 years have looked at males and females, and every time we look, by the way, we see a sex difference. And of the 25% that use both sexes, only a half of those actually compare them directly statistically. So some will just lump them together, and some will just show the data in males and females separately without statistically comparing them. But I think at least our results have demonstrated that when you look, you find sex differences, and that the mechanisms involved may determine whether treatments are relevant to both sexes or just to one. And perhaps this contributes to some of the reasons why basic science studies haven't always translated in clinical trials also. So you can imagine if you do a clinical trial that includes both sexes, when the mechanism was studied only in one, you might actually get a negative result because you're including some patients that would not be expected to benefit. Or conversely, if the signal is strong enough in one sex, you might conclude from the clinical trial that it's beneficial to both sexes when there's really no benefit or even harm. So I think both in clinical research and in basic research, we should all do a better job of including both sexes with sufficient power and doing the right statistical analyses so that we can really answer those questions and figure out what's the best precision medicine strategy for everyone.
Well, that's great. Listen, I'd like to thank you so much for presenting this fascinating work at BCBS. Thanks.
Well, thank you so much for inviting me, and it was really a pleasure to get to present. Thank you.